Hello, everyone. Thank you for joining. We will begin in just a moment. We just want to give everybody a chance to log on. So we'll start in about a minute. All right, why don't we go ahead and get started? We have a lot of information to get through today. So I just want to say hello, everyone, and thank you for joining us for today's webinar as we share important information about transforming cardiomyopathy care. My name is Shauna Plank, and I am the registry manager for the DCM Foundation, or Dilated Cardiomyopathy Foundation, and the Genetic Cardiomyopathy Awareness Consortium, or GCAC. I'm also a genetic cardiomyopathy patient myself. I have a mutation in the lamin or LMNA gene that strongly impacted me and my family. So we're just so happy that you can be here with us today. Thank you for taking time out of your busy workday to join us. We've gathered a panel of experts to address the critical role of genetics and patient support, which is what you'll mostly be hearing about today. So you'll walk away with practical strategies and some actions that you can actually take to make a difference now as you treat your patients with cardiomyopathy. And over the course of this webinar, you'll also get to hear from two patients about their experiences with both of those topics, one being genetic testing and the other patient or peer-to-peer support. I want to go ahead and go to the next slide so we can just cover a couple of housekeeping items. First, you'll see some logos at the bottom here. These are our sponsors for the webinar today, and we could not be hosting this webinar without them. So everyone you see listed here, we really want to thank for their support and their partnership. We're very grateful to have these organizations partnering with us to bring this information for you today. So again, you'll hear practical strategies, real patient stories, and hopefully walk away with some actions that you can apply in your practice now. Let's go to the next slide, and I'll talk about a little of logistics. So at the end of this session, we will have a brief Q&A. And so please, anytime throughout the session, use the Q&A feature of Zoom to insert any questions that you have. And hopefully we can get to as many as possible, time dependent. And all of your microphones are on mute. So the best way to communicate with us is, again, through that Q&A that we'll be reviewing as well. So thank you to Nikki and Justine. They're working in the back end for our technical Zoom assistance, and hopefully we'll have a seamless and great presentation for you today. Another key point of logistics on the next slide is to let you know that this webinar is being recorded, and it will be posted on our YouTube channel. If you go to the next slide, you'll see where you can find all of our recorded webinars. So this is where it will live on the DCM Foundation website. We'll also send a link via email to you as a registrant of the webinar. And just to note that our YouTube channel has a huge library of previous webinar recordings, and using their auto translate feature, you can actually watch them in 54 different languages. So let's go to a little bit of background briefly on the next slide about the DCM Foundation. So a couple of years ago, the DCM Foundation recognized that genetics and cardiomyopathy are so interconnected and really needed to be addressed. And we also realized that genetic cardiomyopathy crosses many different types of cardiomyopathy. So in 2023, GCAC, or the Genetic Cardiomyopathy Awareness Consortium, was found to address that extreme lack of knowledge about genetics and cardiomyopathy, and both in the patient and the medical communities. And it's been something we've been working on very strongly ever since. And so we really just need a more inclusive approach, and GCAC kind of provides that through partnerships with many different organizations. So if you go to the next slide, I'll share some of the meaningful progress that we've made. We actually have 12 different cardiomyopathy patient groups that are part of this consortium, all supporting different types of cardiomyopathy or different genes specifically that can cause cardiomyopathy. It started with 8 patient groups, and it continues to expand. And this momentum really shows that there's a need and interest in understanding the genetic side of cardiomyopathy, which is what we're going to do here today. On the next slide, you'll see who those patient groups are. Again, some of them are the sponsors that you already saw for our webinar today, but we just want to thank each of these groups for participating. It's so nice to have a coalition of all these different groups working together to solve these real problems for patients. And so that's, I think, enough of me talking. We'll get to the good stuff in just a minute, but before I introduce our very exciting speakers for today, I want to talk briefly about the 2 reasons we're hosting this webinar. So the first one is there's clearly a strong link between genetics and cardiomyopathy. However, not enough people are being genetically tested. So there's a huge opportunity to improve this pattern and ultimately save lives through more genetic testing, which you'll hear about today. And the second reason that we're hosting this webinar is that all of those wonderful patient groups exist, as we just showed, but there aren't enough patients being referred to that. So these organizations are there ready to help patients and make connections to others, but it's not always being fully leveraged. And so we have some materials to share about how patients can best find support from these organizations that already exist. And so with that, you see we've collated this amazing panel here today to speak to us about genetics and cardiomyopathy. We'll have Anna Morales, a cardiovascular genetic counselor and an associate professor at Geisinger. Following Anna, you'll hear from Christy Johnson. She is a patient advocate herself, and you'll hear a little bit of her story and how genetic testing has saved lives of many people in her family. After Christy, you'll get to hear from Heidi Salisbury. She's an advanced practice provider at Stanford and also co-founder of the Stanford Center for Inherited Cardiac Disease. She'll be speaking about real-world strategies to improve outcomes for cardiomyopathy patients. And lastly, Hannah Keim will be speaking. She's a co-founder of Heart Church and a patient herself, and she'll be talking about what patient support groups have done for her and those around her. So with that, I'm very excited to introduce our first speaker. Thank you for bearing with me. Let's get to the good stuff with Anna. Thank you, Anna.
Thanks for the lovely introduction, Shauna. And I am in the process of sharing my screen, so bear with me for a second, and please let me know if everything looks all right on your end.
Oh, if you want to go back, Anna, you have it back. You're now in the presenter mode, so let's.
Okay, let me try again.
Okay.
How about now?
Yep, perfect. Keep it there. Thanks.
Here we go. Okay. So it is, a pleasure to be here and reuniting with the community, specifically, joining a panel of real people who have experienced cardiomyopathy themselves and have gone through the process of genetic testing. So I'm really excited about a well-rounded panel today. As Shauna said, I am a genetic counselor and I work at Geisinger as an associate professor in the Department of Genomic Health. I have nothing to disclose. And I would like to begin with a brief introduction and overview of cardiomyopathy. As many of you know, cardiomyopathy is a common heart muscle disease. It has an estimated prevalence in the general population of 1 in 250 individuals, so relatively common. The end stage is heart failure associated with significant morbidity and mortality. And we also know that it is responsible for about 10% of sudden deaths. And importantly, it has a strong genetic basis. As you can see in the image here, showing 4 of the main cardiomyopathies, at the top, each have their own characteristic features and structural abnormalities. Starting on the left, you can see hypertrophic cardiomyopathy, and moving to the right, we have dilated and so on, arrhythmogenic and LV non-compaction. And interestingly, below each of the heart illustrations, we can appreciate that the cardiomyopathies in many most of the time, when we have the right phenotype identified, will result from genetic alterations of the sarcomere, of the desmosome, or signaling pathways involved in cellular processes and tissue development. So the strong basis of genetic cardiomyopathy has been demonstrated to a great extent. So like I mentioned, we have a strong genetic basis, which means also from research that has been conducted for decades that the family members of affected people are at up to 50% risk. And the reason for that is that most cases are autosomal dominant. What does that mean? This is what I show in this family tree here, also known as a pedigree, where the patient shown with the arrow or proband, which is the formal name in genetics, is shown. It's a female. We know it's a female because the symbol is a circle. Males are squares. Affected in this case with cardiomyopathy would be shaded in black, and unaffected in white, no shading. And you can also appreciate above each of the affected individuals 2 sticks, right? And one of which has a blue X. And this is intended to illustrate a gene pair running through the family where everyone with cardiomyopathy has the mutation as indicated by the blue X. However, I would like to bring your attention to this individual right here who is marked with a star. They appear to be unaffected, yet this person had a son with cardiomyopathy. And this is because, as you can see with the 2 sticks and the X at the marking the mutation, this person is a carrier of genetic cardiomyopathy. And although the condition is supposed to not skip generations because it is a feature of autosomal dominant inheritance, we see that, this person did not show any symptoms. And that is something that we can actually see as in the next pedigree to the right, where only one person is affected. But as you can see, the mutated gene is present in every generation. Why is that? This is due to complicating factors that we have learned about how genetic cardiomyopathy behaves in families. We have phenomena like reduced penetrance, where an individual with a mutated gene escapes the manifestation of disease, or variable expressivity, where the person has the mutation and developed the disease, but the disease presentation is so mild, it goes undetected. But the real point I want to make here is that you can have genetic cardiomyopathy with a positive family history or with a negative family history. So it's critically important to understand that cardiomyopathy can be genetic, even if the family history is negative. And so we have accumulated all this scientific knowledge about the mechanisms of cardiomyopathy. And what I would like to do now is discuss what the medical guidelines have made out of this science that has been developed, demonstrating the genetic basis of cardiomyopathy. Here I am showing that genetic testing guidelines for cardiomyopathy have been published since 2009, and that's a long time ago. And updates have been made by different professional societies over time, most recently through 2022. I would like to highlight this particular 2022 guideline, which is a joint publication between the American Heart Association, the American College of Cardiology, and the Heart Failure Society of America, guidelines for the management of heart failure. And what this guideline says about the management of heart failure regarding genetic testing is that patients with non-ischemic cardiomyopathy, in those patients, referral for genetic counseling and testing is indicated, and also for their first-degree relatives for screening and genetic counseling. And they also say the following: no controlled studies have shown clinical benefits of testing for cardiomyopathy, but genetic testing contributes to risk stratification and has implications for treatment. Currently, most often for decisions regarding defibrillators for primary prevention of sudden death, and regarding exercise limitation for hypertrophic cardiomyopathy and the desmosomal variants. Desmosomal variants are associated with arrhythmogenic cardiomyopathy. And what this means is that even though there are no controlled studies, there are many other forms of evidence, good science study designs, robust data demonstrating that genetic testing can inform management. And the committee who wrote this statement agreed that genetic testing is indicated, and these recommendations based on the existing evidence were graded as moderate to strong, which means that the benefits significantly outweigh the risks. And genetic testing should follow a specific process so we can get it done the appropriate way. And what I am showing here is a flowchart that was created by the American Heart Association, published as yet another consensus statement, one of the many I showed you in a previous slide that have been published. And what this does is illustrating the process of genetic testing at a high level. And so at the top, I'm going quickly, the patient with cardiomyopathy is identified, and in combination with family history information, a decision is made to proceed with genetic testing. And then at this point, a genetics professional may be engaged to collaborate. And at that point, the patient may agree to have genetic testing, provides informed consent, or the patient may choose, as shown in the yellow box, to not undergo genetic testing, which is also fine as long as it's an informed choice. And in that case, the person would have management based on their symptoms. But if the results of genetic testing come back and they're positive, as shown in the red box, there are opportunities to change management based on those genetic testing results, which I will explain later. And you may also recommend that their family members get tested, have cascade genetic testing, which I will also explain later. And by testing family members, you may have people in the family who test positive and need cardiac screening and surveillance, those who test negative and can be discharged from cardiac surveillance, or people who choose not to get tested. And that's okay too, again, as long as it's an informed choice. The results may not be positive. They may be non-positive with no variants, benign variants, or variants of uncertain significance, in which case there are opportunities for clinical management just based on symptoms, but also periodic updates of their genetic data that may actually to a right classification of their genetic testing result and more precise genetics informed management. So there are guidelines in place, and we all know as professionals that adherence to those guidelines ensures alignment with best practices, promoting consistency, safety, accountability. And accountability is important because it pertains to supporting patients in their care, and in this case, using genetics informed management for the affected patient and their family members. Both groups can benefit from genetic information. So like I said, strong basic science supporting a strong genetic basis for cardiomyopathy, multiple society guidelines recommending genetic testing for people with cardiomyopathy. And what I will explain next is the why. So whenever a guideline is in place, whenever we do something, take a clinical action, there's got to be a reason and there's got to be clinical utility. So this is a quick review of the latest data. This slide presents data from my collaboration with a group of experts, cardiologists in the genetic testing space for cardiomyopathy, and a commercial clinical laboratory partner with many cases tested over time. And what we demonstrate here with this data I'm about to show you is the utility of genetic testing specifically for affected patients. So as you can see here in this graph, we have two cohorts, the positive cohort on the left and the non-positive cohort on the right. The positive cohort on the left shows specific management changes that were reported by their cardiologists. The different colors on those bars represent the gene in which a disease-causing variant was identified, so positive results. And these are all genes associated with arrhythmia risk, which as a whole are a substantial proportion of all the cardiomyopathy genes. Each bar is for different categories of management changes, which are shown in the middle. And then on the right, you see the non-positives um, shaded in black. And so if you focus on the middle of this chart, we can see that genetic testing impacted the patient's own management for both positive and non-positive results. But also these clinical actions included new cardiac procedures, medication management, such as new medications or changes in the dosage of those medications. New cardiac evaluations indicated for those individuals based on their positive genetic testing results, lifestyle management, and referrals to specialists or clinical trials. The cardiologists who reported data for this study also reported management changes for the patient's family, including family genetic testing and a cardiac evaluation for them. So a key point here is, number one, that when you have a positive result, you are more likely to have a chance to provide an indicated management change for your patient. But also we see value, even though it wasn't the majority of cases, in having a non-positive result, suggesting that we are also seeing some advances in how clinical information and genetic information can be combined to decide how we think about non-positive results, which may, put the patient in a different diagnostic journey or even management journey, as shown here. Family testing is the other benefit of doing genetic testing in the patient, because now we can identify who else in the family is at risk. And what I'm showing here is a figure adapted from another publication from another cardiovascular genetic condition that shows how cascade testing works. So if you start with the person on the left side of that family tree, the circle indicated with the red arrow, that's a female. She's affected. She's 37 years old. She lives in Oregon, and she tested positive. And the red arrow sprouting out of her showing that her first-degree relatives got tested. And as you can see, some of this, all of her family members actually were in Virginia. So this shows also how family members spread across different geographies need coordinated testing to reach the promise of early cardiac surveillance and better outcomes. And then look at her father, turned out to also be affected, 65-year-old affected above her with the red arrow. Then he gets tested, and the yellow arrows indicate cascade testing to his first-degree relatives and so on. So it's a cascade. That's why we call it a cascade. I hope this helps to illustrate how, doing this type of work in collaboration with genetics professionals can help identify people early in their disease course before it's too late. So in summary, genetic testing has utility because it impacts the care of affected patients and their family members. And I feel like we're moving towards a time where we can say that we're reaching precision medicine. It's a vision. And as we can see here in the figure, the vision would be that if we, on the left side of the figure, only limit management of cardiomyopathy using just signs and symptoms, we will have people with benefits, but then others that will not benefit. In contrast, when we conduct genetic testing, the goal will be that each patient will be able to manage their condition using genetic information. So that's what we are trying to achieve together, precision medicine for cardiomyopathy. So we have made a significant advance demonstrating utility for patients and family members. So the next question is, how are we doing? Shauna alluded to this. She mentioned this at the beginning of our presentation. What's happening in the real world? This study is a sneak peek of what's happening in the real world, reporting on our real world analysis in collaboration with a large claims database to explore performance in this setting. For this particular study, we use Medicare and commercial claims data. And we found that despite expert recommendations that have been in place for decades, as shown here, only 1% in this data set had undergone genetic testing. So that was approximately 3,000 people who got tested out of almost 300,000 in this cohort. So obviously we have a huge problem. Primarily because early cardiomyopathy testing diagnosis can save lives. This paper documents the evolution of how we are seeing genetic testing in light of potential benefits, but also unintended harms. Documenting the state and federal laws regulating genetic testing and their adjudication in litigated cases across different genetic conditions, not just cardiomyopathy. And this great review summarizes issues that have been documented, malpractice, negligence in the performance, interpretation, and communication of genetic testing. And they actually mention a case of hypertrophic cardiomyopathy, where they say an example of a genomic test creating a duty to relatives is Pulaski versus Whitson, where the court ruled that a physician treating a patient for heart disease may have legally harmed the patient's son by failing to order a gene panel test for the father for hypertrophic cardiomyopathy, which might have been then informed the son's disease risk. Unfortunately, the son of this affected man with hypertrophic cardiomyopathy died after sudden cardiac arrest. So this, of course, is the worst case scenario. And it's rare, and it should be rare or non-existent. But it's bad because A, someone died of what looks like a missed opportunity, and then litigation, which no one wants, followed. So because of this, I usually get the question, how can we do better? And there are many possible solutions. I have been doing research around this question, but something I have learned through my research is a keyword, teams. Teams. And this is what I would like to address next, the role of care teams in the genetic evaluation. Multidisciplinary collaboration is key. The same I showed you earlier documents this, where they call for multidisciplinary collaboration to provide the best care for patients. Key member of this team are nurses, members of the cardiovascular genetics team in particular. And this has been demonstrated by the literature, where nurses collaborate with genetic counselors, providing all kinds of care and, importantly, psychosocial care for families. Papers that show real-life practice of genetic counseling and testing, where the counseling and the testing was provided by a nurse in a particular proportion of cases. And here, a review stating that nurses play a pivotal role in this space. So again, we have ample reasons to consider genetic testing. So usually the question that follows when I talk about this is, how do I get started? Where do we go to get genetic testing? And what I will do now is quickly provide a summary of the current options available for clinical genetic testing labs. What I will be presenting directly from the lab websites, as published as of a week ago. And I will compare the different features of this testing, as ability to initiate testing by the patient, number of genes, turnaround time, reports of variants of uncertain significance, cost to the patient, and cost to the family members. And I will present this in alphabetical order. So first we have Embry Genetics, and I will let you examine the cells on your own as presented, in allowing you to compare the different specifications for each lab. We then have
Anna, this is Shauna. So I just want to call out that we'll also send this out so everybody can see it. I know in the spirit of time, we have to move quickly through it. So just so everybody knows, you'll also have access to see this after.
Sounds good. Okay, so we'll have this, and then my conclusion. In summary, genetic testing has clinical utility. It enables detection and guides treatment. Teams are critically important, including nurses. And we need programs that improve access to genetic testing. We need more education for families about benefits and to promote preventive care. So my call to action is here. You can learn more about cardiovascular genomic and precision medicine using the modules that have been created by the American Heart Association. You can collaborate with genetic counselors. You can contact a genetic testing lab on your own and initiate your own process with a representative that can help you. And you can start ordering or referring patients for genetic testing. This is all for today. Here's my contact information in case you want to reach out. Thank you again for the opportunity to present.
Thank you, Anna. That was so informative, as always, and really appreciate your insights. We got some great questions that we'll get to in the Q&A as well. So very interesting. Thank you. And with that, so excited now to welcome Christy Johnson, who will tie briefly her patient story directly into what we just heard from Anna about the importance of genetic testing.
Yes,
Go ahead, Christy.
Donna, and thank you, Anna. That was excellent. It really does tie into my story, and you defined so many terms for me, so that's awesome. So first of all, I'm so grateful to be here today to tell you my story and how genetic testing has helped me and my family. My arrhythmogenic cardiomyopathy journey, and so you learned that from Anna earlier, began in April of 2020 at age 47 when I was standing at my kitchen counter during the COVID pandemic and suddenly felt like I was going to faint. My Apple Watch showed that my heart rate was above 200. My husband took me to the emergency room where we found out that I was in a ventricular tachycardia storm and had to be cardioverted 3 times and put on intravenous lidocaine to stabilize my heart. The doctors ordered an MRI, which was not conclusive at the time. I had an SICD implanted when I was in the hospital at that visit. So the picture on the left that you see is me in the hospital 2 years later after that ICD had saved my life after a 10 shock episode. Sorry. But back to the first event. I told the doctors in the hospital about my family history. My father in the picture in the middle died of a sudden death in his sleep at age 52 in 1998. He was the healthiest man I knew. The coroner confirmed that my father did not have a typical heart attack, but said his heart was enlarged. He did not know the root cause. My father's sister, second to the left in the wedding photo, died of heart failure at age 60 in 2010. She had fought heart failure for 20 years, and doctors thought it was from a virus when she was young. It was not until I was in the hospital with sustained VT that anyone considered the possibility of a genetic link. Luckily for me and my family, the EP at the hospital decided to give me a genetic test. I'd been through cardiac testing 9 months before this event, but even with an irregularity in the monitor the results, that doctor did not raise any red flags or order any genetic testing. So when the test came back that I had in the hospital, I found out that I had an autosomal dominant pathogenic variant of the DSP gene. It was on Anna's chart, which leads to arrhythmogenic cardiomyopathy, dilated cardiomyopathy, and a third phenotype which presents like a myocarditis-like flare. I now knew that I was the proband in a genetic disease that was responsible for my father's death. His death weighed heavier on me in that moment, knowing that his death could have likely been prevented if he had been genetically tested and diagnosed and fitted with an ICD. We immediately genetically tested my 2 daughters. One was positive, one was negative. My positive daughter, named Cassidy, was about to train for a triathlon. Endurance exercise can cause more damage and arrhythmia risk in a DSP heart, so doctors encouraged her to greatly reduce her exercise. This advice in itself may have saved her life, but I can't help to wonder if she would have even developed the disease or if she would have much less scarring if we would have prevented her from being a competitive swimmer when she was a child. If we had known about the disease then, genetically tested her when she was young, we would have certainly made different decisions about her activities as a child. Because of genetic testing and MRI results, there was very little argument when Cassidy had non-sustained VT and knew that it was time to get a protective ICD implanted. We know this may save her life one day. You will see a picture of Cassidy on my last slide. My cousins, also in the wedding picture, were harder to convince that testing was important. I was not given a genetic counselor when I was diagnosed, and Anna, that was very upsetting to me. I look back, that is another problem for another talk. But luckily I found Johns Hopkins, and they helped me craft a letter I could send to my cousins. That letter helped convince them to get tested, and one of my 2 cousins and 5 of his children all are positive for this gene mutation. They are not yet showing signs of the disease because they're young, but they're now monitored and on correct medical professionals. Next slide, please. All right, I started this DSP cardiomyopathy Facebook support group in 2021 because I wanted other people to like me. I wanted to find them. It was very hard. This is a rare disease, and this gene is relatively rare, second most prominent arrhythmogenic cardiomyopathy gene, but still rare. So I started it, and it grew very slowly, but it's now catching a lot more momentum because, and now has over 500 members because of efforts from GCAC and other medical professionals who are referring their patients to us. So this is a place for connection, for questions, for gene-specific webinars and Zoom support meetings. One thing that I found fascinating and disturbing in my group situation is how many people were misdiagnosed or undiagnosed for years. One new member who just got genetically tested had been having symptoms for 26 years, had 2 cardiac arrests, and just got tested. There are many other stories like this of people who have been struggling for years, and now they have a diagnosis or are being given better lifestyle advice and treatment plans. We need to test people sooner. Next slide, please. All right, and this is the last one with the messages for you guys to hopefully take from my presentation here. But there are approximately 1 million people in the United States, and only 1% have been genetically tested with genetic cardiomyopathy, sorry. And Anna's research study really highlighted a lot of that. You can save a life by ordering genetic tests for all patients with idiopathic non-ischemic cardiomyopathy, and this really is guideline-directed therapy. Knowing the gene variation allows better patient-to-patient support, lifestyle management, like in my case, exercise guidelines, and medical care for genetic cardiomyopathy patients. With the development of genetic therapies, knowing the gene variation is even more important. It can allow patients to participate in research and clinical trials, and there are now over 30 companies working on these potentially life-saving treatments. Finally, patients don't really understand why they should have genetic testing. All of the things we just talked about, they don't know. So it's really important for medical professionals like you to help explain it to them. Thank you for being here today and for listening to me. I really appreciate it. I'm going to turn it back over to Shauna.
Christy, thank you so much for sharing your story and more about your family and you're just so brave. So really appreciate that. With that, I think Anna and Christy have done a great job of outlining the importance of genetic testing. Thank you both for doing that. At this time, we'll shift gears a little bit and bring Heidi on, Heidi Salisbury from Stanford, who's going to walk us through more about what a comprehensive care looks like for a cardiomyopathy patient and how providing additional support resources can really benefit that individual. So with that, Heidi, thank you. I will turn it over to you.
Thanks, Shauna. Okay, I'm getting a little bit of a glitch when I go to share screen. You want to share screen for me? Not sharing.
Yes, we can do that. Justine, are you able to, or I can?
I'm just, it'll just be a minute. I just have to.
Thank you everyone for bearing with us. Always, it feels like a Monday, I guess. I was gonna say, normally this happens on Monday mornings, but awesome. We'll get those shared in just a moment. And Heidi, looking forward to hearing more about, I think you'll cover kind of briefly 2 things. One is what the care looks like at Stanford and how you've built kind of this world-class program. And then the other would be how everybody here can take actions home, right? Like walk out of here what you can do today if you don't have access to a program like that. But there are many excellent resources out there to help your patients now.
Nikki, which?
And I'm happy to problem solve on my end. I can tell you when I click share, it's just a big 1 and 2 flash. So maybe if you grant me host ability, it might. So
it's practice model DCM care.
Yeah, I'm getting
Yep.
it. I'm getting it. I got it.
Great.
Just give me 1 second. I got it. Okay. We are ready. We're ready. Thank you everyone for your patience.
Thank you. Perfect. All right. Next slide, please. Justine, if you don't mind advancing for me, I don't.
I am. I just can't get it
Oh,
to
no
move.
worries.
Hmm.
I don't know why it's not moving.
Hmm. Let's see.
Well, it's a
Think
pretty
of
picture while we're working through this.
Nice office you have there, Heidi.
Oh, well, thank you.
I don't know why it's not.
Let's
You
see
know what
let
I'll
me-
do is,
you want
In
me
the
to
essence
try
of
to share?
time, Heidi, why don't you start? And
yeah,
then Justine, when you get it rolling, we'll catch up to the appropriate slide. Thank you.
Okay. Okay, I got it now. So if you keep on talking and I will jump in. So thank you, Greg.
Okay, great. I don't see it. All right, there we go. Well, thank you everyone for having me here. I think it's happy. Good afternoon to everyone, and it is good morning still on the West Coast. All right, hard act to follow with Anna and Christy, but it all ties in. I wanted to show here at the Stanford Center for Inherited Cardiovascular Disease, we have created a model in response to the needs of the genetic cardiomyopathy population to really work to take observations from the clinical practice, which is the stethoscope. And if you click, Justine, it's animated, and it's all right if we can just click right through. From clinical observation to our patient community observation and back to the lab to inspire innovations and novel treatments to improve the lives of our patients.
I really apologize to this, but the forward button will not work.
No worries. We can just go to the next slide.
It will
It
not
won't
work the whole
yeah,
thing.
I think there's something glitching on the. Anyway, so while you get, yeah, no, it's not a problem. I can talk to the wind. Again, thank you everyone for being here. I really wanted to focus on creating having a conversation about how to advocate for the best practice to take care of patients with genetic cardiomyopathy. And to do this, we think of the care of a patient and a family affected with genetic cardiomyopathy. We think of it on a continuum. We don't have a cure yet for these diseases. And so we are committing, you want to work with a team that's committing to you and your family through a lifespan and across the generations. And to do that, it's really important to think about that a patient might enter kind of your system of care because they have an event or because they lost a family member or because they had genetic testing and had access to genetic testing. So it's really important to have a multidisciplinary team like Anna mentioned that will help. I'm going to start on this picture here that will help take all of this great information that we're starting to learn about our DNA and our genome and actually apply it in a usable way to improve the care of patients and detect disease early, hopefully preventing any progression of disease and or sudden cardiac events. And so this picture is an example of kind of that overwhelming feeling of we're learning a lot about our DNA. We're learning a lot about disease, but how do we get it from data to actually into patient care? Next slide. Next slide is good. And so we work with the team. Like Anna said, team is key. And we've found that nurses are in a position that is, we can keep going all the way, thanks. Nurses are in a key position to really close that gap between research discoveries and patient care to optimize lives. There's actual guidelines out in nursing literature that help guide the genetic competencies of your registered nurse and your advanced practice nurse. Next slide. In work presented by our colleague Colleen Kalishu, genetic counselor extraordinaire, really showed the importance of the multidisciplinary team, including the nurse, genetic counselor, cardiologist, psychologist, to improve both the psychological and clinical care of patients living with genetic cardiomyopathy or at risk for genetic cardiomyopathy. Next slide. to really color this in and guide our team, our multidisciplinary team, to improve the care of our patients, we centered our nurses on this team, and we trained them with a tool that we call is primed. And we say our nursing is primed to think genetically to improve the care of our patients. And we made this tool in the shape of a circle because, again, the care of patients living with genetic cardiomyopathy exists on a continuum, in a circle, and you might enter the circle at different places. The red here is kind of a classic place where a patient might enter the circle or the system. And that's at intake and triage when you're coming into a clinic or you've had an event. But we know, next slide, please, as we move through, and you can just click, there's only one animation. There you go, thanks. We started, if you were to kind of come in classically through a triage or through the intake process of a new clinic, that's step one. This is where we really prioritize getting your personal history and your family history, like Christy illustrated so well, is key to informing our next steps and who we're going to screen in a family. As Anna showed and both Christy showed, you can go back one for me. Anna and Christy showed it's really key to think about screening family members. Thank you. And then P is the physical exams, making sure the right physical exams are done for our patients. This is something that might seem so obvious, but as Christy again showed in her example, it's often we miss to do the right tests on family members. And then risk, when we do evaluate an individual to see if they have any signs of disease, either by the test or genetically, is there a signal that they are at higher risk and they might need to be protected with a defibrillator, like in Cassidy's case. And that's early intervention, and it does prevent the trajectory potentially of the disease. Interdisciplinary care is really working with your cardiologist, your genetic counselors, and your patient to move care forward. And then committing to patients and families and thinking about their care through the lifespan and across the generations is a really important piece of this. Education and empowerment and community, specifically peer-to-peer community, patient-to-patient community, is something that is really important to the future of our patients. And we're going to talk a little bit more about that. And the D is for DNA diagnostics, as Anna showed, how far we've come with genetic testing and also how much farther we need to go, identifying genetic variations that contributed to the presentation of cardiac disease, and also recognizing that many people are not able to identify that genetic variant. So working with groups and partnerships like we're demonstrating here to improve the reach of genetic testing, and also to develop therapies based on gene therapies based on genetic variants that are identified. Next slide. So when we think of our model, we now kind of, with advancements in the biotech space, we are now thinking of the D not just as DNA diagnostics, but disease-specific treatments that are now hopefully coming into play for patients who have identified variants. Next slide. I want to circle back to how do we get there? How do we get to the place where we can identify our genetic variants and potentially have access to new treatments as they come down the pipeline, access to the correct testing, the correct information community. And the way to do this is really peer-to-peer support, patient support. We've identified at Stanford through our own lived experience and through our patient community's experience that you can offer a certain amount of support in your clinic, in your classic clinical setting, but you're really focused on making sure the person is safe, that you've got the right testing done, right medications. And sometimes we miss that comprehensive support, that education piece. Our genetic counselors are key at delivering this, our nurses, but really leaning in on your patient communities and peer-to-peer, patient-to-patient support to really take that next step in finding out, okay, if how do I get genetic testing if it hasn't been offered to me or my family members, especially family members that might not have access to care. How do I learn about new therapies that might be specific to my genetic variant? What do I do if I don't have a genetic variant? And now there is support in place you're going to hear more about here at the end of the webinar to really engage and learn around these important areas. At Stanford, we've developed a peer mentor program where we can match individuals who've had similar lived experiences. In addition, we have an online monthly support group that's part educational and part support for individuals living with genetic cardiomyopathy. We have a heart transplant support group, a device support group, and then we have a behavioral medicine support groups that are kind of courses that are closed groups for 10-week sessions that deal with, that are designed for cardiomyopathy patients, but focus on stress, coping, lifestyle, and sleep issues that might be specific, that are often specific to the cardiomyopathy population, and of course, cardiac rehabilitation groups around that. And we have a newsletter, website, and an annual in-person event, also really important, where we can come together as a community called My Heart Counts 5K, Kids Fun, Run, and Ride. Next slide. It really has become best practice to engage with patient-to-patient support, with community support. In fact, the American College of Cardiology and American Heart Association included peer-to-peer support and cited it to improve self-care, reduce hospitalization, and enhance survival. So when you think about your comprehensive care for yourself, for your family members, as advocates in your community, you want to make sure that you highlight the impact of patient-to-patient support as a best practice. In addition, the information, the psychosocial support, the facilitating self-care, supporting care coordination, and addressing barriers such as social isolation and depression are focuses of the support, peer-to-peer support and community support that are difficult to really bridge in classic clinical care. Next slide. This is an example, a quote of a patient living with genetic cardiomyopathy. She's on a novel therapeutic that she learned about in a peer-to-peer support group. And she's holding her capsule here, which is a disease-specific medication. And she said, "Tears come to me often these days. I feel like I've been given such a gift and that life is just beginning. This is definitely a game changer for so many. I look forward to doing all the things I've missed for so long. Thank you and the team for being by my side." This is an example of a patient who has access now to a disease-specific medication, and it's bittersweet a little bit, only because there's many patients who don't have access yet, but it's also, she is the perfect example of someone who wants to share her story so that others will have the opportunity and at the very least know to begin to advocate together, the power of community to advocate together for disease-specific medications and gene therapies. Next slide. I want to invite all of you to come and commune with us in person at the next My Heart Counts 5K. There's Greg Ruff, fearless leader of the DCM Foundation, speaking on stage as one of our featured heart heroes last year, and we thank him tremendously for all of his leadership in this space. The date is May 3rd, 2026, and thank you. This is my contact information. Our team is definitely available for questions and collaboration opportunities. I'm looking forward to a discussion, to the rest of our discussion.
Heidi, thank you so much for walking through that amazing program that you've helped to build. It's really amazing. Thank you for sharing that. And in the spirit of time, we would love to have Hannah join us now to talk through connecting the dots from what Heidi shared to how you live that and breathe that every day, Hannah. And as we get ready for that, I also just want to call out, if we don't have time for a Q&A, please feel free to enter your questions, and I'll also provide an email address in the chat that anybody can reach out to anytime if you have additional questions that we're unable to answer today. But Hannah, would love to hear from you now. So please go ahead when you're ready.
No, thank you, Shauna. And I just want to say it's an honor to address you all today. I speak as a patient, having been diagnosed 12 years ago in my teens with genetic hypertrophic cardiomyopathy. I speak as someone who, as the song says, looks at life from both sides now, having survived sudden cardiac arrest. I speak as someone who shouts that life doesn't end with a diagnosis while knowing it most surely will change. And with all that, I speak as the co-founder of Heart Charged, a patient-to-patient support, education, and advocacy group. And if you could change to the next slide. I'd like you to speak as a medical professional to your patients about patient support groups, whether that be mine or another that would better fit their needs and even personality or availability. Though I have my own group, I belong to others and I've gained strength and understanding from each. Here's a recent example from my group. A Heart Charged friend, so someone we connected with through social media, who is a doctor, sees that someone he knows is going to get an SICD within the week. He quickly connects us. The patient is actually an RN and even an ER nurse educator and a nursing professor. I messaged her to let us know if we can be of support. I'm pretty sure she was thinking, and why? I've seen the procedure. Well, my sister and I have spoken with dozens and dozens of people going through ICD implantation, mostly young women or the parents of younger people. We know the questions for other patients as opposed to the surgeon. So the nurse getting the ICD seems to brush us off and we say, well, if you want to know about bras and she immediately stops us and she's like, yes, I was wondering about bras. So right there is where we come in. We can talk with lived experience about things like what an ICD shock feels like when you're conscious. I even have a video of the time I experienced that. We can talk about mental health issues with a chronic illness and a heart that sometimes seems to be out to get you. We do have a lovely satellite in-person support group led by our Heart Charged partner along with his nurses in the UK. We've been invited to the ICD support group at Brigham and Women's. We also offer our support virtually. And as we outlined in a recent article, we were asked to write for the Journal of Cardiac Failure. There are many benefits to such support. We offer 7-day-a-week accessibility to information, answers, and others. We offer anonymity. We have people who will say they've stalked us for years, but now have a question. People can also publicly comment, privately message, or fully engage in a project or initiative. People can relate with others even on the other side of the world. We have high engagement from the UK, Australia, and really around the world. People appreciate knowing they can tap into on-call urgent care for mental well-being. Recently, a Heart Charged friend who is currently in college reached out for a call. Why? She had a cardiac event there on campus. She'd been to the doctor, now she needed a friend. And if you could switch to the next slide. Now for the quick counter-argument and an acknowledgement that not every support group is for every person. So find a new one. Will patients find information that might be considered, let's say, negative? Absolutely, because sometimes having a chronic heart condition is, let's say, negative. It's just plain true, so let's admit it and move on. Thousands of people each year find us at Heart Charged. They find us from a hashtag, a post, a speaking engagement, a friend, and there are other amazing groups which offer support as well, like these here. Through these groups, your patients with any type of cardiomyopathy can find community and the kind of care that comes from being connected with someone else whose own patient experience helps them under yours. We're asking you, as healthcare professionals, to make your patients aware of another type of professional, namely us, professional patients, who are also here for them, offering the patient perspective and rounding out the information packet that helps your patients make more informed decisions they can live with in more ways than one. Thank you.
Hannah, thank you for sharing that and for all the support that you provide to various friends every day. Really appreciate that. And with that, we are at time here. I want to thank all of our panelists so much. And briefly, everybody who signed up for this webinar, you will receive an email with additional resources. Right here, you see a flyer that has more information about current guidelines for testing, as well as links to order tests and some information about some CME and CNE credits. On the next slide, you'll see we're also going to send you a flyer that can be distributed to your patients with all of those support groups that we have shared today. So we encourage you to share that with your patients widely and make it readily accessible. On the next slide, you'll see that, again, we're just going to follow up with those. You can always reach out to me directly as plank@dcmfoundation.org. You'll have that in the email as well. And then because we don't have time for Q&A, I saw Jennifer, you asked a great question about testing unaffected patients. We will provide an answer to that in the email that goes out as well. I think that would be great for everybody to see. And you're also welcome to reach out either to me directly or to info@geneticcardiomyopathy.org as well. We want to thank all of our sponsors here for the DCM Foundation and GCAC, who make the webinars like this and other work that we do possible. And with that, we thank you so much for your time today. And this is the tip of the iceberg. We have a lot more information to share. So please continue to stay tuned as we can provide additional information and resources that can help you take the best care of your patients. Thank you so much. And thank you to Heidi and Anna and Hannah and Christy. Have a wonderful day. Take care.